My name is Jane Grande Allen. I am a professor of bioengineering here at Rice. I am very excited to have been asked to moderate this panel today. We have three clinicians who are going to talk to us about maternal, newborn, and child health. I'm very excited to introduce our first speaker, Dr. Christy Wilburn-Wren. Dr. Wilburn-Wren is a clinical associate professor at UT Southwestern, also the medical director of MCAP. All right, Dr. Wilburn-Wren.
Okay, so the program is called Extending Maternal Care After Pregnancy, shortly MCAP, but our goal is to enroll the patients while they're still in the hospital so as not to burden them with another visit to come back while they're on the mother-baby ward. In order to appropriately follow the data, we have an identification board that directly connects our EMR to the program. Our nurses and the remainder of our staff are bilingual, especially since our population is 90% Spanish speaking. And like we said, we don't want to interrupt the ongoing care. And then to be sensitive to the needs of our patients, we actually specifically underwent culturally and linguistically appropriate language classes to specifically not to be able to show them that, you know, their issues with, not their issues, but our language barrier is important so that we can get to them. And so as I mentioned, we aimed for an enrollment of 70% of the eligible patients that we enrolled, and we actually exceeded that for the first couple of years. And this is a very busy form, but it's a form that's necessary to capture as much information about the patients that we enroll. And as you can see, it includes everything from the date of enrollment, your medical record, your delivery date, all the way over to what issues do you have? You have issues with transportation, food, housing, et cetera, so as to approach the patient as a whole person as opposed to a woman who had a baby and that's where her life ends. And this is our registry dashboard in order to keep a real-time log of how many patients we're enrolling, how many we're losing to follow-up, and so on and so forth. To date, we've enrolled close to 6,000 patients. And so in terms of what we do for our patients, in the little blue rectangle at the beginning, we scan all the zip codes to make sure that those patients are in our high-risk area. We enroll them before they leave the hospital. We assess their social determinants of health. And then the patients get a home nurse visit to begin with, and then they're followed up either virtually or in person with a visit or a phone call at 1 month, 3 months, 6 months, 9 months, and 12 months, hopefully if we can keep them engaged. And in terms of our SDOH assessment, we check to see if they are on food stamps, do they need clothing, formula, do they have a separate bed for the baby, do they need diapers, et cetera, do they need help with job searches and transportation, and a lot of these other SDOHs we impact by including our community health workers. And so this was just a study that we did showing that a significant majority of our patients not only had issues with transportation to and from their appointments, to and from the grocery store, and to and from pretty much everywhere they go, relying heavily on public transportation, but also the impact of mental health on our patients. And it seemed like for the study that we did, the majority of our patients who had mental health problems also had other significant comorbidities. And then in terms of screening them, their their depression screen as well as their anxiety screens were significantly higher in this particular population. And so again, we had a community-based organization partnership that helped us with everything from diapers, baby supplies, et cetera. And then in terms of our little bit in terms of being able to help on the side of the newborn healthcare, we had Dallas Healthy Start, which was like a sister program that also did a similar follow-up and home visits with the moms to assess the baby's health and overall well-being. And so this is one of our initial mobile health units. It's big and blue and readily visible. And so in order to impact as many of the issues that are associated with maternal mortality as we could, we took on a multidisciplinary effort with nurses, nurse home visits, doctors, APPs, community health workers, social services. We had a direct line to a behavioral health counselor and psychiatry group, as well as a pharmacist who would come out with us on each visit. And so this is just a slide tallying, discussing an award that was given, and in terms of how we're actually truly impacting innovations, as is the topic of the day, in terms of thinking outside of the box, in terms of delivering extended postpartum care. And then this is another award that was given that we will skip. So after we found success and worked out some of the kinks with MCAP, we started tele-MCAP, which is technology-enhanced maternal care after pregnancy. And it wasn't high-tech, it wasn't a big deal. So we found that 98% of patients in America have cell phones. People look at their phones 144 times a day at least. My husband says I look at my phone 300 times a day, which he's probably right. And then even though only 8% of households lack internet, 14% of them usually use their phones. So we decided to meet our patients where they are and use audio-only phone calls if that's what they needed to follow up. So something as simple as a monthly phone call: how's everything going? Are your needs being met? Do you have a need for us to make you an appointment with a mobile unit? Everything was taken care of without impacting the patient's need or her issues with transportation, et cetera. And then this was just based on the success we had with prenatal visits during the pandemic, where 95% of our patients readily accepted the virtual option. We also found that among our urban population, the patients who had comorbidities also had a higher burden of health-related social needs, which just showed us that we need to take a broader approach in terms of what we're looking at in terms of our patients' maternal mortality. And then after MCAP and tele-MCAP, we went a little bit further. So MCAP started in the southern region of Dallas County. Tele-MCAP went into the eastern region, and we plan to, in order to not overburden the system, we did serial enrollments. We started with 400 patients and then 800 patients after that, just to see how much of a burden we could handle. And then again, tele-MCAP met our goals of enrollment of 70% and above. As of late, various political changes have sort of shifted our enrollment and follow-up, but that's a discussion for another day. Our next steps are further expansion. So as one of the previous slides we had this morning showed, there definitely needs to be rural representation, and with that in mind, we're expanding out into Hunt County and East Dallas and some of those other areas where there's only one hospital in that county, and that hospital has been forced to close its emergency department since then. Ooh. And so going into the East Dallas area, we again do a whole patient sort of approach with diaper distribution, food, youth and adult and senior programs, and significant community outreach. One of our maternal fetal medicine specialists is going out there specifically assessing the need for syphilis treatment and follow-up, and we've had a great outcome for that. Here's the picture showing one of our, well, it's beyond the health fair, but one of our patient health fairs, where we distribute not only health care, but food, diapers, medication, and discuss other resources that are available to the patients in an effort to impact maternal mortality. And then this is the design for one of our new units that's going into Hunt County. And so the services that we're going to provide beyond what we're providing on the initial unit are family planning, medical management of comorbidities and mental health issues, as well as screening and treatment of STIs, including syphilis. And so we plan to go out to that area 2 days a week, and then 2 days a week in Hunt County, 2 days a week in East Dallas, with the 1 day for following up and making sure patients keep their referral dates. And so the goals are for us to maintain our enrollment, follow up the blood pressure, mitigate circumstances involving their mental health and STI screening. And so the key takeaways are that maternal mortality, yes, it's important. It's a complex issue. And it's really important to obtain accurate data such that we can standardize treatment so that everybody's getting the same number of resources for the level of acuity that they need. And we also found that the classic triad that we were originally attributing maternal mortality to has pivoted. It's more cardiovascular disease, because it seems like everybody now has a hand on hemorrhage. You're already ready to go with your uterotonics, your compressive devices, et cetera. So now we need to figure out that the patients are getting older, have different needs, and need closer follow-up. And that's where the postpartum care comes into 1 year to sort of transition the patient from postpartum patient, optimizing her health, getting her ready for another pregnancy should she desire, and then transitioning her to her own PCP. And there are still disparities that remain that need to be worked on. So we like to emphasize the need, again, for good data. We wanted to identify our target region without trying to boil the ocean, as one of my colleagues says. We can only do so much with so little. Consider the limitations of the patients. If they don't have a computer, use their phone, because almost everybody has a phone. In order to not burden them to come back, enroll them in the programs and teach as much as possible before they leave while being culturally sensitive. Using our electronic medical record system to maintain that data. Have an answer for the issues that we identify. So if a patient needs diapers, then we get them diapers. If they need car seats, then we get them car seats. But just use a community-based approach in an effort to mitigate these circumstances. And finally, to flip to the model where patients are not always relying on the hospital per se for their care, but they can also get care while they're out in community and be empowered to help their community otherwise. And then MCAP is a community-based system where we've gotten help from private funders, public funders, the state, and actually anybody else who had a hand in wanting to mitigate maternal mortality. Our local evidence has shown that there are still gaps and there's lots of work to be done. And here's our group with the group that supplies us with diapers, et cetera. And then here's our clinical group with Drs. Martin, Nelson, and Duryea, and myself in the middle. Thank you.
Thank you so much. All right, we're going to move forward to our second speaker. That was wonderful. Now we're going to switch to Marydale Peterson. Dr. Peterson is the Executive Vice President and Chief Operating Officer of Driscoll Children's Hospital.
Thank you so much. Good afternoon, everybody. So where is Driscoll? Well, I'm going to show you a map in a minute, but we started off, Clara Driscoll was a very Renaissance woman. In case all you Texans don't know that, she saved the Alamo. It was going to be razed for destruction, and she bought it and deeded it back to the state of Texas. But anyway, she left her estate, she was childless, to take care of, quote, the poor children in South Texas. That's how we got our start. So we're a mission-based hospital, tertiary children's hospital, and to my great delight, we expanded our hospital footprint by a new hospital on the border of Texas, way down in Edinburgh, Texas, which is really fabulous. We also have a physician practice group of, I don't know, a couple hundred pediatric specialists and a health plan. So that informed a lot of what I'm going to tell you about today when I went into my 13-year journey in population health. So what am I considering South Texas? This is our main region. It's 36,000 square miles, like South Carolina size. And we have some, urban type areas, Brownsville, McAllen, Edinburgh, Laredo, Corpus Christi, and then there's a whole lot of ranch and farmland and rurality in between. I was sharing with my colleague earlier, I learned last week, I knew Texas had a lot of ruralness, but I didn't realize we were 80% rural. And so it's a challenge. Geography is a challenge for us in serving this population. I firmly believe that rural Texans deserve just as good a quality of care. So transportation's come up a lot, and so we've had this system of transportation in place for really decades. We've been lucky to have some generous donors. We have 5 fixed-wing aircraft, helicopter use, and various ambulances. I've lost track how many we have. And we have bases that we have our aircraft, so we can transport patients to our 2 facilities if needed. But what is different is we fly our doctors to clinics around this area. So when you go back and you see those little boxes, We have clinics in not just Corpus Christi, but Victoria, Laredo, Brownsville, Harlingen, McAllen, Edinburgh. So, those patients, it's really hard for them to get to us, so we go to them. There's also a thing called internal checkpoints in South Texas. In case you don't know, you got to get through the checkpoint 74 miles from the border. A lot of families, 1 in 4 children, are in families with mixed immigration status. So it's a challenge for those families. So on my journey into population health, I was still practicing part-time, 20 years as a pediatric anesthesiologist and pediatric intensivist. There's a lot of joy in working in a children's hospital, and there is some sadness. The saddest things to me are seeing children in a hospital for preventable things. And that's the truest sadness. And when a colleague of mine who's a pediatrician, the state of Texas expanding managed care into the Nueces region, we looked at each other and we said, what do we want to do to make an impact on our community? And we both knew that the preterm birth rates at that time, around 2007, 2008, were around 15.1%. They were significantly higher at that time than the state and national averages. So we set as our big, hairy goal that we were going to improve premature birth rates. We did not know how to do that, okay? We had no clue. So we went and asked our OB colleagues, what do you think we should do? And they said, well, we think our patients need more education, especially around nutrition. So we said, okay. So I got a Title V grant, and we started these educational baby showers, and we did a lot of them. We did thousands of them. And over time, we did see that we made a little dent in that. In the meantime, I hired a nurse abstractor. In our first year of operation, I had her abstract every single delivery record and tie it to the obstetric record. And then I gathered up all of our OB colleagues, and I said, let me tell you what I learned. 20% of the babies you deliver go to the NICU. 30% of the inductions are not medically indicated. Did you know? Did you know? Well, they didn't know that. They go to work doing the best they can every day under difficult circumstances. And I truly believe that. And so that was the beginning of conversations on how we're going to improve that. And with that, further conversations, we did improve a lot of things. But in further conversations, I had this aha moment one evening when we were gathering. And they said, Mary Jo, we are just worried with this complicated pregnancy that either the baby is going to die or something bad is going to happen to the mom. And you guys do a great job in the NICU. And I'm like, thank you for that. I now understand our missing link. We have 0 maternal fetal medicine doctors in that entire 36,000 square mile region of South Texas. And so I'm a health plan. Our hospital doesn't even deliver babies. But I went to the CEO and I said, look, these preterm births cause suffering, and they're also a huge financial hit to our health plan. I'm, making or losing money every other year depending on how many catastrophic babies I get. I said, I need to manage this risk. We need to begin to set up maternal fetal medicine clinics throughout South Texas. And so we did. And we recruited some great MFMs. We collaborated with our OBs. We shared data. And we started trying to improve the care. So in the first few years, actually it was over about 10 years, we saved over $1 billion. We reduced traumatic births, elective inductions, and improved overall birth outcomes. Our flying doctors, some of them are located permanently in those areas and others fly into the various areas that are a little bit less populated. But these are some of our visit numbers. They're very busy practices, seeing a lot of complex pregnancies. And it's been previously talked about, what we're seeing is the women coming to us who are pregnant have a lot of comorbidities when they become pregnant, whether it's obesity or high blood pressure or diabetes, it's a lot. And so, but we all believe that if we provide really great care, that we can ameliorate a lot of that and improve outcomes. So in South Texas, we have 1 in 4, 25%. So our Medicaid health plan covers half the Medicaid deliveries in all of South Texas. And 1 in 4 women have diabetes, which is significantly higher than the state and national averages. So we've been trying to work on some alternative payment models. I know Episcopal Health talked about that earlier. I'm a firm believer in aligning what we can do financially to support practices. A lot of the practices, most all we work with are private practices. They're not university practices. They're not any big conglomerates or anything. They are smaller practices. And so this is a practice in Victoria, and with this alternative payment model, working with them, we were able to decrease preterm births, C-sections, and ER visits. Talk to you a little bit about the Nurture program. This was a study we did with some funding from Episcopal Health Foundation and our auxiliary, and we worked with Dell Medical School and Factor Health. So the aim was, we know we have a high rate of diabetes in pregnancy, and so this particular program was a study. So 1 out of 4 were randomly assigned to be the intervention group, and we chose all pregnant women over age 30. And then the intervention was that we would give $20 HEB gift cards, well, twice a month gift cards, HEB gift cards. We would have nutrition consults, they were telephonic, and we would, we have a lot of other wraparound services, but this particular, everybody gets those, but this particular program was related to food, and they would receive a kit in the mail every month that would have recipe cards in English and Spanish, shopping lists, QR codes, that they could, take with them to the grocery store. And we had sort of sessions on how to cook fresh foods. And so we enrolled, there were 1,200 deliveries during a little bit over a year's time point. And we saw that vaginal deliveries were higher in the intervention group than in the control group. We had lower rates of preterm births, and we had lower lengths of stay for our newborns. The return on investment, so you saw the $234, which is a pretty nominal expense per pregnancy. If I added up all those costs, I have another slide that shows that, but if I added up all those costs on the savings from C-sections and hospital days and those kinds of things, it was $1,700 total savings. So I think, we don't know exactly why that relatively small intervention caused those results. Is it because there's more trust in the healthcare system? Did we really make an impact on nutrition? I really don't know the answer. And so that was 1,200 patients, members. We would like, I think, to expand this to see, is there an ROI? And then the question is, will the state of Texas actually give us credit for that $236 to save $1,700? Because right now that $236 is coming, we're a nonprofit, it's coming out of the margin, it's coming below the line. To make this sustainable, instead of the state saying, oh, you lowered the cost $1,700, we're going to take $1,700 out the next time we actuarially analyze what your per member per month premium should be. No, we need to get that money back that we can reinvest in the community, right? And so these are the overall impacts. And I just am proud to say that despite the challenges, severe OB shortages, the poverty, the levels of diabetes, South Texas has the lowest severe mortality and morbidity by region, and I think it's because of our hardworking, on-the-ground clinicians and community-based organizations that work hard for this community. Thank you.
All right, our final speaker is Jacqueline Alvarado. Jacqueline is the Maternal Fetal Focus Program Manager and Nurse Practitioner at Texas A&M Rural and Community Health Institute, based in Fort Worth. Here you go.
Hello, everyone. So at Texas A&M, we have an extension called the Rural and Community Health Institute. Our organization focuses solely on rural communities across Texas. I'm based out of the Fort Worth area, and I lead all of the maternal health initiatives. So for those of you that may not know, as she just mentioned, 80% of Texas is rural, but specifically, almost half of Texas is considered a maternity care desert. So what that means is there is not a birthing facility in these counties. So no birth center, no hospital to deliver babies. So these women are having to travel very long distances to get prenatal care and to deliver their baby. It's proven that rural women have 60% higher risk of maternal death, as well as increased mortality and morbidity with having to travel. And so in these rural communities, not only are they having issues with just access to care, there's workforce shortages. So we're not able to actually provide the care because we don't have the nursing staff, we don't have the OBs, the nurse midwives that are there. So if you take a look at the map, this is a current up-to-date March of Dimes. All of the red are considered deserts. So again, these women are traveling very, very far just to get prenatal care and deliver their baby. Most of these women just elect not to get care because whether it's a transportation issue, maybe they're at work, they can't drive 3 hours to just go to their routine OB visits. In these rural communities, they've noticed an increase in postpartum hemorrhage, hypertension, as well as mental health issues for these women. So at Texas A&M, we decided let's take a step back and try to be creative on how we can help women other than just direct patient care, which I'll talk about here shortly. So we devised an OB emergency simulation training program. So we noticed that these rural EDs, these women are dropping in to deliver babies as well as postpartum follow-up. They'll go to the nearest ED versus back to where they delivered their baby. So we noticed that these providers are not prepared for obstetrical emergencies. And so we have gone into these rural facilities and we're training them on how to handle these situations when these women present. We've also had to be, very creative because they often have less supplies. Most of them don't even have more than 1 unit of blood available if we did have a hemorrhage in that situation. They don't have any trained OB providers. A lot of these communities, they staff one advanced practice registered nurse in the ED, and then they call a physician in if needed. And so just customizing these training based on the staff that they have. And then we've also noticed just if a woman does present, a lot of them don't have a protocol in place for transferring that mom to the nearest OB facility. So as you all know, simulation's great because we are able to go in and practice real life scenarios and, start these protocols, these processes, and allow them a safe space to learn and really understand why these complications need to be addressed. So we created an entire simulation program focusing really on low fidelity with the resources that they would have available at their hospital. And so we do an in-person simulation training, and then we follow up with quarterly virtual refreshers. So again, this is just like a picture of what we've created, very, very low cost. And so we give every facility a mom and Natalie, again, very low fidelity. The baby is filled with water, something that they can recreate. And we focus on, one, how to catch a baby. I'm a nurse midwife, so for me, it's my love. It's so fun. But for other people, it's terrifying. So first, we just say, hey, let's do just the basic hand maneuvers of what to do if a woman does come in delivering a baby. After that, then we go through postpartum hemorrhage, shoulder dystocia. We cover hypertensive crisis in pregnancy as well as postpartum. Because again, we've noticed a significant increase in postpartum preeclampsia in emergency rooms. And so for our ED providers, a high blood pressure is nothing for them, but for our postpartum pregnant moms, it's a big deal. So walking them through that, as well as cardiac arrest in pregnancy. After we do this simulation, we then go through their emergency department and help them build an emergency kit. So it's going to have all the things you need to deliver a baby, as well as the protocols for all of your meds. Because again, we're customizing it to what they have. So I'm not going to go over all the uterotonics that they won't have access to, because that's not going to help them in those situations. And then we help them build a protocol for their facility. So we initially piloted this in July our first one was Mitchell County. So that is, if you're kind of familiar with the West Texas side, it's near Snyder and Sweetwater. Their closest OB facility is about 30 minutes away, but they are right off of Highway 20, Interstate 20. So they've had a lot of just drop-in pregnant patients. Like they've delivered a 24-week twins, and they did not have the capability to handle that. And so we offered a 2-day training, and it was great. We had a high volume of nurses, EMS that came, and again, low fidelity, hands-on for them to practice these. We did a pre and post test just to gauge their knowledge, and as you can see, they almost doubled their knowledge from pre-simulation to post-simulation, and then they're scheduled for their first refresher in January. The other great thing is going in these facilities, they say, hey, I really want to get a baby warmer. And I'm like, okay, let's find that grant funding. So then I partner with them, and we worked on getting them a baby warmer for their ED. The next one we did is in Knox City. Closest OB facility is in Abilene, so it's about 73 miles away. So again, we did a 2-day training. It was great. Very little supplies that we need. Through this, I also identified we really need to work on quantifying blood loss. So that was something that we've incorporated. Just each time we do these simulations, we learn a little bit more of more education that these facilities need. So again, we did our pre and post test, and as you can tell, a significant increase in knowledge from pre and post simulation. This one we just recently did in Ward. This is the man, he's a FNP, a family nurse practitioner, and he was so grateful because he's like, I had no idea all of these things, and he emailed me last week saying, thank you, because I just delivered a baby. So it does happen. So currently, this is all of the simulation sites that we've been able to do across Texas. We're growing every day. We're scheduling more facilities. But this is just a way that we were thinking, how can we take care of these women in indirect ways through the community? Because they are presenting, and they deserve just as good of care as if they were in an urban area. The second initiative that we've created at the Rural and Community Health Institute is a prenatal care program. So what that looks like is, out of our Fort Worth campus, we have an advanced practice registered nurse that will do a telehealth visit in these maternity care deserts. So these are for women that really cannot get access to care. It's not that they don't want to, but whether it's transportation or work or whatever it may be, we want to be able to still provide them some care. So we're partnering with FQHCs and rural health clinics, and we are doing a telehealth visit while we have a community health worker in the home with the mom. So that way they're getting that in-person, one-on-one care with like hands-on, while we have our advanced practice registered nurse virtually. And so we are taking care of these women from early conception all the way till about 35 weeks, and then we transition them to a delivering provider. So we're having that continuity of care, as well as making sure that we have a plan in place for delivery. And then we follow them for the whole first year postpartum. So that's just a great way to also provide some wraparound services for these women, because again, there's so much in these rural communities. Food insecurity, like they don't have normal grocery stores. Some of them only have a Family Dollar. So being creative, how can we get you fresh fruits and vegetables? How can we make sure we're getting you connected to WIC and lactation support? And so just also being that emotional support for these areas, because they're very isolated in these rural communities. So again, just a little bit more how it's set up. We are state funded, so we are very fortunate that we go out there and we fight to get the extra funding to provide these services free to these women and these communities. The simulation's also free for every facility. So what we really zoned in on is networking, getting in these communities, being boots on the ground. That's the only way that this works, is sitting down, meeting with the women in the community, asking what they need, and getting all the stakeholders that you think would be important to getting a program to be successful. So that's pretty much, yeah.
Thank you. These were all amazing. Thank you so much. So one of the thoughts that came across my mind is that I sensed I wrote down a lot of trends, and so definitely transportation was a big one, but I was also really interested to hear just about your funding models, and I know that you just Jacqueline touched on this as being state funded, but I wanted to know a little bit more about how do you provide for all of your your mobile units and your other clinical activities that you've been describing to us.
Well, for us, obviously, being a state safety net hospital, we had state funds. However, it was literally us pounding the pavement to look for assistance from private funders and other people who were on the same page in terms of seeing maternal mortality as a crisis. We had one person that was their job was to seek out any grants possible. And so we did what we had to do. And then the other thing is to mitigate the funding issues, we sought out our community partners to pick up the slack where we were lacking.
So we try to use, so we have the health plan, we have our hospital, we have our clinic, our practice group. The physician practice group probably loses about $70 million a year. We, as a leader, I look at the consolidated bottom line. So, some years the health plan loses money, some years it makes money. We really have tried to work hard at supporting the practices through that first dollar. So the state of Texas gives Medicaid health plans. For those of you young people out there that don't know this, it's a per member per month full risk. So you can have your good years and your bad years, right? But mitigating risk is a big thing, and the foundation of mitigating risk is having a solid foundation of access to primary care. So that's pediatricians, obstetricians, family doctors, which is difficult. And so one of the things we've done is we've made sure we have a partial capitation model, and then we have some add-on payments to support these practices kind of through thick and thin. And we partner with them in delivering innovative models of care. I touched on a little bit some of the medical homes. We have that in our pediatric practices, and now we're delving into the obstetric practices. I'm still a believer in private practice, even though, the government payer systems are not really keeping it very sustainable. But we're trying to sustain it as long as we can, because I still think it's a pretty efficient way of doing it. Now the MFM, so as you know, they're hard to find, and they go through all this extra training, so they're expensive. They are, and they do a great job. And so really that is all directly funded through our health plan. And yeah, it benefits the whole community, even non-health plan members, but we really found that was the way to improve care. Now, if the health plan goes away, I'm not sure what's going to happen to the MFM clinics, because they would not be sustainable as a separate private practice.
I mean, not much on mine, but again, we're state funded, but every 2 years they're constantly meeting, proving why maternal health is in such a struggle right now. And so we didn't really have that issue, but we want it to be sustainable because that funding is not guaranteed. So we are still out there getting grant funding, as well as with our sustainability of our prenatal care program. That's why we've chosen to partner with a lot of FQHCs and we're essentially workforce for them so they can still bill for the visits. And 100% of our patients are Medicaid patients. So that funding comes from there.
Thank you. We have questions. Thank you. Let's get started with you.
Thank you so much, Lisa Hersham from Northwestern. So this is fantastic and really inspiring. And I think it sort of makes it not just from global to local, but local to global, because each one of these examples are things that I've either heard about or working in a lot of the settings. I do mostly implementation research in countries in Africa, largely in rural settings. So like, for example, the neonatally and sort of how do you actually, the concept of EMONC and BMONC, which is CMONC. So the idea is that women are delivering in places which don't have blood, which don't have things, and there's a tension about trying to get them only to places where they have this higher things, and the women can't get there. So I think some of the skills building is really, really important for that. I think the other thing which I was really interested in is, as women are coming in with more comorbid diseases, often success is controlling them during pregnancy as opposed to what happens to them longer term. And so I was really interested in, from the first, and I'm sorry, I'm totally jet lagged, so I've forgotten your name. As you're getting these women, with their hypertension and diabetes, how successful are you at getting them then into primary care and getting them sort of long-term into those areas? Because we're actually doing some work with that in the Dominican Republic, and I think a lot to learn from what you're doing.
I think one thing that we're doing to sort of mitigate that is that we actually are treating them on site. And then if there's a need to go to the emergency room, obviously they go. But once we get to the point where they have actually finished the program at 12 months, they're given a graduation. And before they get to that visit before then we find them a PCP to refer to at that point. And it's usually somebody that's in their area, because the majority of our women's health centers also have primary care clinics attached to them. And so that's a way that we can get them to transition out of our care into the care of the PCPs. I mean, we have a population that is challenging, and there's a significant issue with non-compliance. So, I don't want to lie and say, yes, they stay all the time, but they are really motivated the majority of the time. It's just the other issues that prevent them from following up with their visits.
Yeah, I think the question on whether they're staying, I think, is the funding issue. So it was only, a year or 2 years ago that we got, and it still has some kinks to be worked out, extension of Medicaid benefits in Texas to the first year. But Texas is a non-expansion state. So if you're an adult and not pregnant and not disabled, you are out of luck, basically. We have our indigent care programs that if you're in a hospital district, but not all counties have hospital districts. So like none of the counties on the border have hospital districts. So I think, having insurance, some kind of insurance is a very big barrier. We have actually started working on identifying a PCP during pregnancy. And so our OBs are currently so overwhelmed right now that they really need that extra help. So, if they have a cold or they have some other kind of condition, they can see a regular PCP for that and not overload the OB offices. So in some of the practices, we're actually helping them find PCPs at the same time that they're pregnant to save our OBs.
My question is for Jacqueline. I'm so impressed by what you're doing, and I wonder if you could talk a little bit about your ambitions for scale and what some of the barriers to getting there are.
For simulation or prenatal care?
Both.
For both. Okay. So, wow. Eventually, we want to have the OB simulation in every county, every hospital or rural clinic that is interested. We've also expanded it to be low volume LNDs, because we also identified less than 100 deliveries a year, that they're not getting the exposure to any of these complications. I went into one in Frio, which is near about an hour outside of San Antonio, and they had this thing called a JADA. It helps with postpartum hemorrhage, but they didn't know how to use it. They're like, we haven't had a hemorrhage in a couple of years. Teach me how to use it. So ideally, we'd like to be across all of these maternity care deserts. So about half of Texas is what we're looking at. Our goal was just to have 5 simulations this year and we've already hit that. So again, word of mouth is the great way. And in these rural communities too, it's telling their sister county, hey, they have this program, it's free, enroll, and we'll come do the training. We're also keeping it interesting for them, like, hey, if there's something else you want to see, let us know. We are, like, another team wants to see a breech delivery and practice that, or a prolapse cord. So we're keeping it updated and interesting to what's applicable to them. And for prenatal care, the biggest barrier right now is getting the buy-in from the clinics and the FQHCs. Because for us, we're not here to make money. It's not it's not a moneymaker for our organization. It's truly a service that we're providing. So we're trying to make it profitable for these clinics and these FQHCs. That's what we're saying. You bill, you keep the money. There's nothing that you would have to compensate us for. So really, it's getting them to be on board, try it out, see that it works, and give it time, right? Like, these are technically their patients. They're going to come back. And so I was just going to mention about the hypertension. We have nurse midwives, and so they are primary care providers in these rural communities. And so they get to follow them that whole year, and then we're making sure that they follow up with the FQHC primary care provider. So we're trying to do this networking, but it is hard. That's the biggest barrier. And Texas is so huge, as you know. And so, I don't know, one day at a time, but we're getting there. We've also extended to do like OB service line evaluations too. So we want to keep as many L&Ds open. So now we're going into these areas that are struggling and doing a free evaluation of, okay, what is the issue? Is it staffing? Is it truly financial volume? What is it? How can we help you?
Thank you.
Just one other comment, and this is really, we've seen in, well, one particular hospital, a border hospital, but we had a health plan member that was a maternal death from hemorrhage. And so we went in and looked at that, and we sent, an obstetrician there to kind of work on retraining, making sure that the AIM bundle and all of those things. And then we had a second near death. It was a woman who had had a prior vaginal delivery, and she had fetal heart tones that were bad, and it was 42 minutes before the obstetrician arrived. She had a ruptured uterus. She barely survived. The baby barely survived. And so the subsequent year, I was so concerned about this, I actually did a quality kind of workshop or presentation at Texas Hospital Association, which had a lot of the rural hospital CEOs there. And so I do think it's important for rural facilities, and this particular hospital with the issue wouldn't be classified as a rural facility, but it's still a facility that lacks resources, let's say, of a Houston facility or a Corpus Christi facility, whatever. And, really those hospitals should not be offering VBACs. And, if you don't have in-house obstetrics or in-house anesthesia, do a scheduled C-section if the mother doesn't want to go to a hospital that can really have the resources for that. That's about policy. That's about safe care. And so all hospitals can't be everything to everyone. And I think people have to realize, what they can and cannot do as well. Comments on that?
Just really briefly, it just highlights the importance of the maternal levels of care. So if you do specialize in what you do, then you become a regional referral center, and you're ready for that kind of situation versus a smaller or a lower volume hospital or a rural hospital that's not equipped to it, and they literally use up all their resources on one patient. So maternal levels of care, teaching, standardization, simulation, is all
Just
very,
having
very
a
important.
workforce you can manage it.
Exactly.
Okay, we've had a patiently waiting question over here. Please go ahead.
It's going to be real quick. I just want to learn a little bit more about screening tools. That I heard that you guys are screening for syphilis, for example, right? EMCAP. You had problems with nutrition. Do you guys like screen for nutrition? What kind of biomarkers or point of care devices that you guys use? And also for emergency delivery, how do you assess, like, for example, infections and all of these things? Just basically want to hear what is done, and then what is your wish list for what could be done, like for ultrasound devices that are smaller, more affordable, and then other tools that are really in need. So we guys over here that do research can help more.
That was a lot of questions at once. It's fine. So in terms of like on-site screening, our APPs are sort of trained in terms of what to look for in terms of just cervicitis in general. So we have microscopes. They can do the swabs and the testings on site. And then some of them they can treat acutely if there's a high degree of suspicion. Otherwise, it's sent off to a lab that they come and pick up daily when we take the unit out. In terms of the syphilis treatment, we used to rely heavily on the local health departments, but we can't really do that now because of various funding issues. So we sort of screen for risk factors and exposure and that sort of thing. And so as of late, since a lot of the emergency rooms have closed and the health departments are sort of sparse and whatever else have you, we have actually developed a program where our pharmacist actually brings out the penicillin if we have a high degree of suspicion. So we have started to treat them on site. In terms of an ultrasound for us, since the majority of our patients currently are postpartum, we don't need one, but they have made smaller portable ultrasounds that are really more affordable than the giant hulking machines used to be. And then for your last question, something that I would wish for is more units and more staff so that we can go out to more areas and not just concentrate on our side of the state, but going into her side of the state as well.
I think we could improve testing for syphilis. It's complicated, and you're a better expert than I am, but I know we had a child, an infant, and the mother repeatedly tested negative. And the baby ends up with these lesions and all. The dermatologist was the one that diagnosed it finally. And they went back. The reason why the mother didn't test positive, even though she had full-blown syphilis, was the flu zone phenomenon, that it overwhelms it. You have to dilute the specimen and know to dilute the specimen or in order for it to be positive. And so I do think it's complicated, the testing. It could be simplified, but you're the expert on that. But I've just seen some patients that have been appropriately tested and have fallen through the cracks.
And last thing, I think unfortunately, like you said, the testing is, it's a layered sort of testing, and, it takes a while for results to come back. But if you have that index of suspicion, as somebody mentioned earlier on another panel, the penicillin isn't that expensive. So if they have exposure or suspicious lesion, then we treat them on site.